Good afternoon. Good afternoon, everyone, and I'd just like to welcome you all to today's webinar on local anaesthetic transperineal biopsies. My name is Nicola Leavold from BXTA, and it's my privilege to serve tonight as the host and moderator. We're pleased to bring together a pair of esteemed experts to explore how you can successfully introduce a local anaesthetic biopsy clinic into your hospital. Associate Professor Matt Brown has really been a pioneer in this field, establishing Australia's first local anaesthetic biopsy clinic at Fiona Stanley Hospital in Perth back in 2018. And over the past 7 years, Professor Brown, together with a dedicated team, which includes Mr. Emanuele Constanza, they've really refined this technique to deliver a high quality service for all the men of Western Australia. So this session is designed to provide evidence-based insights and the latest research developments that are shaping clinical practice. We hope this discussion will offer valuable perspectives that you can apply in your professional roles. Just before we begin, a few brief housekeeping notes. Today's session will be recorded and you'll receive access to the recording and any supplementary materials afterwards. And we really encourage your engagement throughout this session. So please submit your questions using the Q&A function within the webinar, and we'll address as many of these as possible throughout the webinar. So without further delay, it's my pleasure to introduce you to our first speaker, Associate Professor Matt Brown. Please join me in welcoming Matt. Thank you.
Thank you, Nicola. Yeah, my name is Matt Brown. I'm a robotic surgeon and urologist at Fiona Stanley Hospital, which is one of West Australia's largest tertiary public hospitals. And joining me today.
Hello, everyone. My name is Emanuele. I'm one of the clinical nurse specialists, urology at Fiona Stanley Hospital as well. And I'm pretty much concentrated my profession into prostate biopsies and robotic prostatectomies as well.
Fantastic. So just moving on, here are our disclosures. The views that we're presenting today are our own and not necessarily reflective of the organisations you see listed here. So in today's webinar, what we'd like to talk about is the why, the what, and the how of local anaesthetic TP prostate biopsy. And to do so, I'd like to share with you our journey as a hospital in undertaking LATP biopsy and some of the lessons we've learned along the way. So let's start with the why. So when I started at Fiona Stanley Hospital in 2015, I walked into what was a highly efficient, cost-effective, rapid turnover prostate diagnostic service. It was called the One-Stop Prostate Clinic. And this clinic served over 200 patients per annum. And it revolved around a nurse streamlined program where patients were referred with 2 abnormal PSAs or an abnormal digital rectal examination. And in one stop, they had a consultation and a transrectal biopsy. Then they had nurse-led follow-up by telephone call. And this was a very effective clinic, worked very, very well. And in fact, was published our experience of over 1,000 patients with very good results. But what was clear to us was that we needed to integrate MRI. The PROMISE and PRECISION trials from the UK showed us that MRI was critical to triaging which patients required a biopsy and which patients could be safely observed. And not only that, but the MRI could inform the biopsy, enabling us to improve the diagnostic accuracy of our biopsy. So we made the move towards integrating MRI. And indeed, the Europeans came out and recommended that quite early on. But this introduced a number of problems.
Yes, since I started my role as a clinical nurse specialist in 2024, the urology service of Fiona Stanley Hospital asked me to review how we're managing patients going for TP prostate biopsies. The problem was the integration of MRI, lack of patients' compliance. Those patients didn't have any clue of why they were going into this MRI before the prostate biopsies, and also having MRI prostate booked into the public system give us a waiting time of 3 to 4 months. So that's when I decided to change a few things on our clinic. So the new model that I introduced in 2024 for one-stop prostate clinic at Fiona Stanley Hospital is based on a concept of 28 days pathway that they use in England as well. So first of all, it's a nurse-led clinic. So we follow up these patients from the day of the referral until the day of the prostate biopsies. The clinic was based on paper, so we were checking the paper every week to make sure the patients waiting for the PSAs, they've done it. We've been calling them, chasing these results all the time. It was time consuming. And it wasn't really efficient because, of course, we have been checking this PSA constantly, and sometimes people were not compliant in repeating PSAs or MRIs tests. So since I introduced the new model, now we are paperless clinic. So we got trackers where we follow our patients. We're receiving chat-outs appointment to remind us when to check the PSAs or the MRIs results. Time is reduced due to the fact that the MRI waiting time is 5 to 10 days now, because I'm referring the patients to external providers that meet the Medicare criteria, so they don't have to pay for the MRI prostate. At the same time, the patient receive a first assessment with me. So I explain exactly what to expect during this journey, why they've been referred to us, and I deliver education regarding PSA and MRIs. So the solution, so what the changes are, like a referral, a triage into a nurse prostate biopsy phone assessment. We generate a booking into the outpatient clinic. This provide numbers and a real track of what's happening with the patients. The patient have a phone call with the nurse, with me mostly, will assess their past medical history, the reason why it has been referred to us, family history of prostate cancer, for example, social history, medications, allergies, height and weight, and the plan. Sometimes those patients be referred to us with only one PSA deranged. So we need to organize the PSA test, MRIs, and a consultation after the MRI has been done. Of course, now the patients are very compliant because they receive their mind, they know what they're doing, why we're doing that, and they receive phone calls to follow-ups to make sure that they know they need to repeat the test on time. MRI prostate waiting time is been reduced by from 60 to 90 days to 10, 15 days, sometimes even 5 days if it's urgent. The outcome of this, we have got an efficient clinic with planned follow-ups, patient education and improved compliance. Definitely now they can understand what PSA it is and why we're pushing them into an MRI prostate, reducing waiting time from referral to prostate biopsies. And for our patient in category 1, so means that you need to be done in 4 to 6 weeks, we're aiming to do our prostate biopsies in 28 days from the day they are ready for the MRI prostate.
So integrating MRI has been a challenge for us, and I think running a high volume diagnostic clinic is a bit like running a garden. It does need constant attention, and problems develop and bottlenecks develop, and Emanuele is kept busy resolving those bottlenecks in the interest of the patients. But I think that some of the key messages Emanuele has just told us are really to do with the importance of having a tracker. So as referrals come through, patients can be followed up. The importance of streamlining care and using all the available resources to get people through the pathway as quickly as possible, and the value of continuity by way of having the same point of contact every time for the patient in that journey. And with this program, we have achieved that one-stop model where patients come in once for the biopsy. But the second challenge we encountered was that we wanted to shift the needle. We wanted to move to transperineal biopsy, shifting the needle out of the feces and to the perineum, such an intuitive and yet highly important step. When I was in Guy's Hospital, I was trained in transperineal biopsy with Rick Popert, who remains one of my mentors. And it was really him who impressed on me the importance of transitioning, that moving to transperineal biopsy at Guy's was associated with, of course, reduced complication rate, as you would expect, but actually of equal importance was improved cancer detection rates. Now, it was interesting to see the publication of the Translate trial just a few weeks ago, which showed that not only was transperineal biopsy able to be done safely without antibiotics, which I think was probably the main thing, but secondly, again, improved cancer detection rates. So when we compare transperineal to transrectal biopsy in terms of improved detection rates, I guess there are a couple of reasons for that. For us, having MRI to inform the biopsy is a way of improving that detection rate. But also, I think fundamentally, there are a proportion of cancers that lie anteriorly, and transrectal biopsy has quite a lot of trouble in accessing those lesions. And I think the third thing is that if you're biopsying a prostate and you're coming at it coronally, then really you only sample small segments of the peripheral zone, as opposed to an axial approach where you get a large trajectory through the tissue. And I think probably the improved detection that we are seeing has come from a combination of those factors. Not only was improved detection and reduced rates of infection a key impetus, but we were also increasingly concerned about fluoroquinolones. So traditionally in our transrectal biopsy clinic, we use ciprofloxacin. And there is increasing concern about fluoroquinolones causing not only tendon disorders, which we all know about, but also cardiovascular toxicity and aneurysm formation. And then on the back of that data, the European Commission, in fact, have recommended against using fluoroquinolones for prostate biopsy. So improved antibiotic stewardship was a key part of that piece. But we have this one-stop prostate clinic. And when I was trained in transperineal biopsy, it was transperineal biopsy under general anaesthetic with a stepper grid and a template. And it took over half an hour. It was a long procedure and some 32, 34 punctures of the perineum. And I could not see how could we move this standard of care approach from general anaesthetic to a local anaesthetic approach. So like many of you, I experimented with freehand biopsy. I placed Venflon cannulas in the perineum, put my ultrasound probe in the rectum, and then tried to line up the trajectory of the needle with the array. But what it felt like is that I was playing chopsticks with the prostate. And this was not a technique that I felt I could do reliably. I didn't feel like I was doing a great job. And I certainly didn't feel like I could teach someone else how to do it or roll it out at scale under a local anaesthetic. But fortunately, a solution came along. That solution came in the form of the precision point device. The precision point device is deceptively simple, but the secret sauce of it is that we can have our needle for biopsy maintained in alignment with the array reliably as we move through the patient's perineal tissue. And Matthew Alloway, the inventor of this device, actually came to Fiona Stanley and spent a day with me in theatre teaching me how to use it. And this absolutely revolutionized my practice, because all of a sudden we went from 32 punctures of the perineum to just 2. A procedure that took 30 minutes now took 5. And because of the freehand technique, we could steer underneath the pubic arch and access difficult lesions, which were otherwise impossible or very challenging with a template approach. Certainly the technique becomes simple with experience. It's reproducible, and we've proven time and time again, highly teachable. And for the first time, this was a technique that I felt was realistic for local anaesthetic. So in 2019, we rolled out at scale local anaesthetic TP biopsy using the precision point device. Dr. Catherine Ong is a registrar who is now appointed to training, and she did an audit of our initial 246 cases from September 2019 to June 21. And she compared that to our previous database of the last 3 years preceding that of 876 transrectal biopsies. So when she did that audit, predictably what we saw is the patients going forward for LATP were pretty much the same in terms of age and PSA to those who went for trust biopsy. But look at the cancer detection rates, 72% in LATP relative to 57% in transrectal. And look at the complication rates, reduced rates of complication in TP compared to transrectal, and that's driven by a reduction in sepsis. Interestingly, we also experienced the same thing that I had experienced at Guy's Hospital, the same thing that has been published in the Translate trial. We have found superior cancer detection and superior cancer characterization by moving from local anaesthetic truss to local anaesthetic TP. So, ladies and gentlemen, colleagues, the why. Why do LATP? Well, it's accurate, it's safe, reduced rates of sepsis and complication. It's versatile. It's certainly fast and efficient. It is teachable. It is very reproducible. It's convenient for patients. And I think this is something that we probably need to emphasize a bit more.
Absolutely. Patients are really happy. They're stressed about the procedure before, but we talk about the procedure a lot before. One of my role is to call them before the procedure, explain step by step what's happening on the day, so they come in the procedure room ready for that. But the beauty of this that they can eat and drink. They don't need to fast. They just stay with us 2, max 3 hours, and then they can go back to their normal life the day after. Minimal pain, minimal complications. They're very happy. The experience at the end of the day is always said, "Oh, I thought it was a little bit worse than this," but most of the patients tolerating really well, really well.
I've actually found that a bit of a revelation, because when we talk to these patients ahead of time, we actually offer them both GA and LA. And I'm constantly, well, I used to be amazed by everyone seemed to choose LA. And it's for the reasons we just talked about. They don't want to be admitted. They don't want to have to fast. They don't want to be knocked out. They don't want a sore throat after. They want to be able to work and return to normal life as quickly as possible. And they really value that. And I think as well, by integrating LATP biopsy, it's absolutely critical in reducing our waitlist pressures and improving access, and certainly compatible with the pathway.
Yes, absolutely. And then I have to say, these patients, sometimes they say us, better than the dentist, to be honest, because they're thinking, that pain is very well tolerated during the procedure.
Yeah, I guess we set the bar pretty low there to be better than the dentist.
Yeah.
All right. So ladies and gentlemen, that's the why. And let's talk about the what. So the what's pretty simple, because what we're trying to do is provide a quality local anaesthetic TP sector mapping biopsy with cognitive directed assessment of targets as well. So our approach is this modified Ginsberg protocol. We divide the prostate into 4 sectors on each side in axial sections. So if you look up at the screen here, we have the posterior medial and posterior lateral sectors. So you could just do a posterior sector, but we like to subdivide it so that if there is a positive core in the posterior sector, we know whether it's near the neurovascular bundle or not. Then we have the mid section, which is just above the posterior. It's kind of on the border of the transition and peripheral zone posteriorly. And then we have the anterior sector, which climbs up the anterolateral horn of the prostate. One of the things we often talk about is when to biopsy the very anterior-most part of the prostate, that is between 11 and 1 o'clock. Now, I personally don't love biopsying that area because it can be uncomfortable. We have to top up the local, and we're getting very close to the urethra and bladder neck. So that patients who have very anterior biopsies, they're the ones that get hematuria and pain and discomfort. So what I personally do is I will biopsy that area if I have to. And I feel I have to, of course, if there's a lesion there, an MRI, or if the patient has, for instance, a return for a repeat biopsy or a rising PSA in the absence of a positive biopsy. So that's when I worry about getting that very, very anterior sector. Otherwise, I just go up the anterolateral horn. In terms of targets, so for cognitive directed targeting, I tend to incorporate those targets within my sector pots. Some of my colleagues have separate pots. That's fine, but I will just take additional samples of a target if there is one in the relevant sector. So let's talk about the how. So Emanuele will talk a little bit about the setup and our equipment.
Yes, so we're using an ultrasound biplane probe that goes into the patient rectum to target our biopsies. So we're using a Ghani chair with stirrup, where we put the patient in a stirrup position. We got a basic probe cover and cover tape. As you can see on the video, we're using a little sort of condom to protect the ultrasound probe. We're using the precision point device, a 40 ml catheter tip syringe filled with 30 ml of ultrasound gel. That's we're using this gel into the patient rectum to create a little bit of space for the ultrasound. A skin preparation, we clean the skin before the procedure with an antiseptic solution. A towel for patient to hold the scrotum on the side, and also to provide a little bit of dignity and make sure everything is covered as much we can. We're using the biopsy gun with a specific length, and we also demonstrate this to the patient because they're quite loud, so make sure they know what to expect during the procedure. And then the local anesthetic that we use a little bit for the skin, just to numb the skin, the perineal area. And then most goes into a deep local anesthetic around the prostate. And we're also using some pots for specimen collection. So this is our setup room and chair. So on your right-hand side, you can see the Ghani chair, and also you can see the trolley. Usually I'm standing actually there between the patient and the trolley. And then they're having an ultrasound machine on the right hand, and the doctor will sit between the legs in the front of the patient. And then this is our chair. On the left side is our chair. As you can see, we just cover. We're using this slide sheet here in case of a vasovagal reaction for a patient. We can flat the bed and make sure the patient is in flat position.
Just while we're talking, Emanuele, this is our setup. This is what we have. It's actually borrowed from the gynae clinic. Both of us would prefer a different setup, whereby the patient's legs are held for them in position, because when they have to sit in this weird looking chair, they actually have to, with active muscle contraction, hold their legs in position. And I think part of that means they sort of tense up during the procedure a bit. Whereas if we had sort of more of a stirrups, perhaps, it would hold their legs passively and they'd probably be more relaxed. And also because of the stirrups, you can raise the legs above the level of the heart, for example, if you wanted to, and sort of improve blood flow.
Yeah, I'm pretty sure this chair is for inspection, like more invasive, more than for procedure. In fact, one of the limitations of this chair doesn't have a CPR security system. So it's an electrical chair, so it takes time to lie flat in case of an emergency. That's why we are in the process to possibly change it.
We just wanted to share that with you, because if you are setting up your service, I wouldn't necessarily put forward this as the best way of doing it.
Yeah,
this is just what we'd have.
Yeah. And this is our setup back table. So from right to the left. So first, what we use is a skin prep. The doctor will clean the skin with a solution, and then we will using the LA for skin, the little syringe, 6 ml. We just on the skin. Then the doctor will use the ultrasound probe and the precision point. After that, the doctor can visualize the prostate on the ultrasound and proceed with a deep local anesthetic for the nerve block. That's the big syringe with a spinal needle. Then we're using a biopsy gun in a specific length. Then we have a little saline for needle rinsing there in the middle, and a little bit of wet dry post-procedure. So we clean every time we take samples of the prostate. We clean before to give back to the consultant. And then on the left side of the screen, you can see all the biopsy pots, right and left. And usually we take 2 samples each pot, but we can increase if we need to target more of the areas required. And then the syringe filled with ultrasound gel that the doctor will squeeze inside the rectum.
Yeah, I think the syringe with the ultrasound gel is quite useful. Just to it basically gets fecal contamination out of the area where the ultrasound is and improves visualization. Of course, provides lubrication and improves conduction of the ultrasound wave. So again, it's just a little trick that we found quite helpful. Just in terms of the local that Emanuele was talking about. So what we use is lignocaine because it has the fastest onset of the locals. And we actually dilute it 50-50 with saline. And we do that because it enables us to inject a larger volume and still stay within the safe payload for the patient. And we also buffer it with bicarbonate. And that was something I learned from the plastic surgeons and the GPs, because it just reduces the acidity of the local and makes it less uncomfortable. As Emanuele mentioned, we have a skin infiltration using a tiny needle, a 27 gauge needle, and I tend to bend it a little bit. It just seems to make it easier to steadily inject just under the surface of the skin and the subcutaneous tissue on the approach for the precision point. The deeper block, yes, needs a longer needle. And in terms of the technique, when I learned local anesthetic TP biopsy, I tried all sorts of funky things. I tried to reproduce what we did transrectally with the Everest block. I tried to do a pudendal block. But what I've actually found is something very, very simple. And that is that you just create a tunnel of numbness from skin to prostate capsule in the area in which you are going to work, which is typically about 1 o'clock and 11 o'clock relative to the anal verge, and about 1 centimetre or so away from the anal verge. And that is on the precision point device, typically the lowest aperture of the needle carriage. So in terms of the block, what I'd like to show you is that puncture here on the right side.
Really great. Really great. And this is again a little uncomfortable, this bit. Very good.
So on that video, what we're showing is the block going in on one side. And what you're observing on the screen is the needle going through the subcutaneous tissue very, very slowly, because again, the plastic surgeons and GPs say that the faster you move an instrument through tissue, the more tissue disruption you cause, the more stretching of fascia you cause, the more pain you cause. So if you move slowly and just gently hydrodissect with the local as you go, it's much less uncomfortable. And when we do the block, we do that slow technique. We advance the needle, we push the local in before the needle so that the needle moves into local as it goes. And we inject the local very slowly to reduce that stretch pain. And remember, the local's buffered as well, which really helps. So what we do as we do the injection is we try and, as you heard on the video, have that sort of calm, reassuring demeanor. And Emanuele's watching the patient like a hawk while we're doing it to make sure they're comfy. And then once the block's in, then it's really important for us to wait, and I'll come back to that. So in terms of the tips for a successful block, then it's having the patient's been clearly prepared. So manuals talk to them before they've even come to the clinic. They know exactly what's going to happen. There's no surprises. And I think when a patient knows exactly what's going to happen, they can be calm about it, because there's no shock, there's no surprise. We have that calm atmosphere. We buffer. We do the vocal local. So we talk to the patient as we inject. In the example I just showed you, it was more just explaining as we go, just reassuring. But we have other patients who like to have a laugh, have a chat about their weekend, their grandkids, and it all helps because it takes your mind away from what's going on. And it's slow, it's a tunnel, and it's important to wait. So one of the things that was a bit of a hard lesson for me was the importance of waiting, because I'm a little bit impatient sometimes, and I just want to get the procedure done for the patient, get them through and home. And Rick really impressed on me the importance of waiting, because local takes time, doesn't work straight away. You've got to wait. And if you just take the time to wait, the reward is there, because the patient's far more comfortable, the local's actually working, and a comfortable patient is a patient that's easy to biopsy and has a much better experience. So those would be our real key tips, I think. So moving on to the biopsy technique itself. So what we do is we make sure we fasten that precision point securely. We use that Coban I mentioned to provide extra padding for the probe, and we make sure it's exactly at 12 o'clock. I tend to use the lowest aperture. You don't have to, but that's what I use. And as you do the biopsy, there's a little bit of an uncomfortable time for you as a surgeon when you've got to puncture the fascia, and it's a real push and a pop, and it doesn't feel so nice, but you have to, because if you don't puncture the fascia, you can't move properly with the access needle. Before I do the biopsy, I always test my block. And the way I test it is I put the spinal needle in and I just tap the capsule, and I look up and see what the patient's doing. And the patient's still chatting to Emanuele and talking about the music, then I know we're good. So then we can start the biopsy. To do the biopsy, we use a sagittal working view, which you're all familiar with, I'm sure. And we use the axial view to work out where we are in terms of medial to lateral. And just like the local infiltration, it's gentle, slow, small movements. That's all you need. Those moves, gentle, slow, and small, gets you through the tissue and helps maintain a comfortable patient. So this is a biopsy in action. This is Rick Popert in London doing a precision point TP biopsy. And if you look at the lower end of the screen, you can see the access needle sitting in tissue. And now you're going to see the biopsy gun going through the tissue, tapping on the capsule and then firing. And you can see on the axial that is a posterior-medial biopsy. So the next biopsy is to shift the array slightly. Now, movements of the array are not twisting movements. They're sort of X, Y, Z movements. And because if you twist the array, what can happen is that the needle guide can come off the array slightly, and you can have a little bit of trouble visualizing. So, but if you move the array in a more linear way, it's more reliable. And what you can see from the biopsy we're showing you now is just how quickly and how efficiently you can get those sector maps. So now he's going to do a posterolateral, I think, or maybe still a mid. Okay, biopsy. So that just shows the principle. And as I mentioned, it's fast, it's efficient, it's teachable, and it's easy to pick up. So ladies and gentlemen, colleagues, just to summarize, I guess our journey with LA biopsy, I'd put to you that it's rapid, it's efficient, versatile, and done well tolerated. Certainly cost effective. If you put it against a GA procedure, absolute no-brainer. Against a transrectal biopsy, well, if you still do that, well, I guess it probably is still cost effective if you reduce the rates of infection in ICU. It is absolutely integratable into an efficient one-stop model. There are no limitations on prostate size or cause. You can absolutely do cognitive targeting and systematic biopsies. We have high cancer detection rates for prostate lesions, and I believe the learning curve is quite short. If you have avail yourself of the training courses and mentoring, absolutely, it's quite a short learning curve. So I guess at this point, keen to hear if anyone has any questions or in any way we can help further.
Thank you, Matt. Yeah, so there's a Q&A function at the bottom of your screen. So if anybody does have any questions, please type them in there. We do just have a couple of questions around patients choosing general anaesthetic. So just wondering how many patients, when given the option, what percentage of patients have general anaesthetic versus local anaesthetic?
Do you have a feel for that?
So I have a chat a lot with those patients before, because I'm always telling them, in case you're having, you need a prostate biopsy, we offer you local anesthetic or general anesthetic. And I have to say, when I talk with them about the local anesthetic, how it is done and how, they recover from the surgery, the fact they don't need to come and, early in the morning, they don't need to fast. They really prefer it. I have to say, if the patient are very anxious, they don't really love needles, I think they're not good candidate, definitely. So we got the option of general anesthetic. But I have to say that more we educate the patients, better it is for the LA. They understand exactly what's happening, and they will accept definitely more than GA. And also, GA, some patients are not suitable for GA as well. So the LA is definitely a good option for those patients there.
So if you had a rough figure in mind, if you sort of had, would you be talking 50% GA, 70%?
No, I would say we are more than 80% choosing local anesthetic.
Yeah, it's interesting. That was a real revelation to me, I have to say.
And have you had patients come back for a subsequent biopsy when they've had their first one under local anesthetic?
Yes, definitely. And they said, that's okay. Last time they get prepared. They come with their own music, they know.
Which is a good thing, but you don't want Emanuele's music unless you can avoid it.
It's all Italian opera.
Yeah.
Anyway, so definitely, we had some people who's in surveillance. They repeat their biopsies in a certain time from the first one. And definitely they prefer to come back with under local anesthetic again. Actually, we have patients that had the first one under general anesthetic, and then they decided to go under local anesthetic for the second one, because that's okay. So I want to give a go.
Interesting.
And sorry, carry on. Sorry, I didn't want to cut you off.
That's okay. Just want to say that the patients, wants to know all the aspects of what the LA involved and what GA involved. And I think the more they get educated, better it is on their choices.
We also have a handout, don't we, that sort of explains
exactly
the procedure.
So before the procedure, they have this phone call assessment where we explain the procedure, but also we sending them a lot of information, an info pack at home. They got, how to take the medications, how to get ready for the procedure, what to expect. So they are, very well prepared. I think that's key in this role.
Well prepared, absolutely.
And do you have the option of using a light sedation?
Not for a local anesthetic, because we don't have any anesthesia available in the room. It's done in a day medical procedure unit. So we have a procedure room. As said, there is not a sterile settings. It's just a normal setting with a sterile field.
Yeah. Yeah, we don't, I personally don't feel comfortable giving IV sedation. Emanuele is very capable medically, but I don't feel comfortable giving IV sedation myself.
And just another question. So what are the complications you've had in your experience using this technique?
I think the main scourge of all prostate biopsy, and this was also my experience with transrectal, was occasional vasovagal. And what I found with transrectal is because the patient's flat in that sort of fetal position, the effect of the vasovagals was actually quite mild because they never really dropped their blood pressure too much. But the challenge with the setup we said, and I sort of alluded to that, how it wasn't optimal, our chair, is that they are, when they have a vasovagal, you want to sort of act fairly swiftly. I don't know if you would speak to that.
Yes, yes, as Matt said, vasovagal is common complication. Not so many patients, but if it is a complication, it's a vasovagal. To be honest, rarely the loss of consciousness is just like a little bit of low blood pressure. We make sure the patient is on a flat position. We raise the legs. We just check the blood pressure. And then we don't want the patient to walk straight away after the procedure. Usually we transfer them back in a bed and in the recovery area. They stays with us until the blood pressure is back to normal. We give some food, and then once they've done a wee, they can go home. I think in a couple of years, we didn't have any admissions after the procedure, and we had some vasovagal, but they didn't require any medical intervention, so medical intervention after.
And the other things we worry about with all prostate biopsy is retention and hematuria. I honestly can't remember the last time I ever had a retention. Have you had any retentions? Or?
No, not really. But again, we educate them. I educate them a lot about this. So it's expecting to have blood into the urine and semen for a few days after the procedure, sometimes even weeks after. So they know. So sometimes they call me back and they said, "Oh, I had a little bit of blood today," but they got good urine flow, so they don't need any readmission or emergency presentation.
I guess speaking about the complication rate, one of the things that we do is to reduce, we feel, the risk of retention is the use of an alpha blocker. So for patients medically able to take an alpha blocker, we'll often prescribe a routine alpha blocker starting the night before the procedure and carrying on for a few weeks later. And there is a bit of evidence in the literature that this reduces rates of retention, and something that we use.
And we educate them again in the use of this medication as well. There's a lot of education involved. We really want them to be prepared. And I think, again, education, it makes everything much easier for the patient because they can understand. I have to say, nurses deliver this information in a way that is more familiar to them, in a language that they can understand. So that's really, really good. I have to say, a lot of people really say thank you for what we do there.
Absolutely.
That's great. Well, we don't have any more questions from the audience, unless anybody has any last minute questions. Just some thanks for the great... Oh, sorry, we do have another one. So is the tip of the ultrasound probe in the rectum or pressed against the perineal skin?
Yeah, so the ultrasound is a transrectal ultrasound because that gives us a nice long view of the prostate. So it's a transrectal probe, but it's a longitudinal array, so to give that maximum visualization of the trajectory.
Okay, well, I think that's all of our questions. So I would just like to thank all of our attendees for joining us today, and a very special thanks to our expert speakers, Professor Matt Brown and Mr. Emanuele Constanza. And thank you for sharing your valuable insights and experiences. We hope you found today's session both informative and thought-provoking as you consider implementing or enhancing local anaesthetic biopsies within your practice. So just as a reminder, this recording will be provided with you along with a short questionnaire that we would greatly appreciate some feedback on today's webinar, as it helps us to continue to improve and tailor future events to your interests and needs. So on behalf of BXTA, thank you once again for your participation. We look forward to welcoming you to future webinars. Take care and have a great rest of your day. Thank you.